So we're joined today by Dr. Cesar Luo, who is one of the presenters at this year's ASRS meeting. Welcome.
Thanks so much for having me.
And at this year's ASRS, you are giving a presentation on diabetic retinopathy progression in anti-VEGF versus FA implant-treated eyes who are lost to follow-up. What are some of the main findings or takeaway from your presentation?
So the point of the study was to evaluate if there was a change in the way these patients present when they're lost to follow-up. So we know, unfortunately, patients with diabetes tend not to follow up to their appointments, and sometimes it's out of their control. And so the goal of the study was to see if there were some durability issues here. There are some good data showing that patients who have pan-retinal photocoagulation in proliferative diabetic retinopathy actually have better outcomes versus if they only had anti-VEGF treatment alone. And so we thought, well, there's a durable treatment like fluocinolone acetonide in the eye. And with the data actually that showed that potentially there's some retinopathy regression from the FAME trials, perhaps these patients also would have a reduced risk of neovascular complications if they didn't come back for whatever reason. So the main findings were quite consistent with what we hoped to find, was that patients who had a durable therapy inside the eye seem to have a reduction in their risk of neovascular sequelae. That include neovascularization of the iris, as well as vitreous hemorrhage, and as well as tractional retinal detachments. Interestingly, in the fluocinolone acetonide arm, we didn't see any eyes that actually presented with tractional detachment or rubiosis if they were lost to follow-up for more than 6 months. Whereas in the anti-VEGF arm, 1% of patients actually presented with those complications. But with vitreous hemorrhage, actually 5% of patients in the anti-VEGF arm actually came back with bleeding inside the eye, whereas the fluocinolone acetonide arm, only a single eye came back with vitreous hemorrhage. And then we also wanted to look at retinopathy regression. And so we also found some interesting things, really in the severe non-proliferative arm, patients really at the highest risk of conversion into proliferative disease. Patients that are only treated with anti-VEGF, 10% of eyes actually progressed to proliferative disease once they were lost to follow-up at 6 months. Whereas in the fluocinolone acetonide arm, only a single eye, one eye, less than 1% of patients actually progressed to proliferative disease. So the durability really speaks to protecting these eyes, especially if they could not make it in for their appointments.
And so how might the takeaway of the topics from your discussion apply to ophthalmologists or retina physicians in their day-to-day right now?
Yeah, that's a great question. You know, when we first came up with this idea, this didn't have anything to do with the pandemic. I just knew that with the data I saw last year's ARVO meeting, that this is something we need to take a look at in increasing the accessibility for durable treatments. But I think it's even more relevant now with the COVID-19 era. These patients sometimes, again, they're just so scared to come in. There's all these data saying that these patients with diabetes have increased risk of hospitalization and mortality. So I can understand if I had diabetes, I would be very fearful of coming into the office. And so if there's a way of actually being able to keep these folks out of our office and be able to potentially slow down the progression of their diabetes and protect them, then that's great. Now, the flip side of this conversation, though, and then that I think retina specialists fear, is the steroid response or the intraocular pressure elevation. So that's actually an important thing to talk about. I think when it comes to fluocinolone acetonide, what happens if they don't come back for 6 months? That's actually a concern. Are they going to come back with really high pressures? Are they going to come back with full-blown glaucoma and be blind from that reason? And we actually didn't find that in our analyses. No patient actually needed filtering surgery when they were lost to follow-up for 6 months. And if you look at the mean average of intraocular pressure upon return, it was 15 pre and it was 16 post. And so there didn't seem to be a large data signal here arguing that patients who were lost to follow-up actually would have a rise in their pressure on fluocinolone acetonide.
What might be your next steps in this research?
So I think it is important to actually just consider this as a potential therapeutic option in patients who Again, you might be concerned, may or may not be able to come back. And even outside of the pandemic, this is a treatment I think we're getting more used to. We know that these patients need a steroid challenge. And so if there's not going to be a pressure response, it's unlikely to happen on fluocinolone acetonide. And so potentially this actually is something we can start considering for our patients if we're concerned that they might not make it back. And it might prevent them from visually threatening complications of neovascularization.
Mhm. And lastly, I was just kind of curious, what are you most excited about in this field at this particular time that we're in?
In specific to diabetes or retina in general?
Retina in general.
I think retina in general, I think the what I'm talking about right now in terms of durable therapies really is the most exciting thing. And I think all the research that we're seeing right now, so the topics that were coming on in ASRS, we're all kind of looking at different facets of the same topic, whether it's with gene therapy application or suprachoroidal delivery. Are there ways that we can increase the durability of our treatments while still being safe? And I think that really is the crux of everything that we're seeing right now in retina, and I think that's what's the most exciting thing. And so, to have a treatment available right now that does have a durable profile is already great, and something that is in our armamentarium. And I think as more studies come out and more technologies come out that argue towards effective and safe durable therapies, I think it's going to be great for our patients long term.